Presentation on high school hockey injuries by John Cavanaugh. Some of the most common high school hockey injuries are concussions, shoulder injuries, sprains and strains. Mechanism of injuries for concussions and for shoulder injuries are body checking, as we can see here. There's violent forces being applied. One player moving in one direction, another player moving in another direction. Mechanism of injuries, again, for concussion and shoulders can also be collisions with the boards. The boards surround the rink, keep the players and the pucks in the rink. Oftentimes the players are checked into the board, or they can be or collide with the board in their movement down the ice. Mechanism for the strains and sprains usually is a quick change in direction and the speed at which the athlete is traveling. As you can see here, the athlete is traveling. Here he happens to get hooked, falls to the ice. During that fall, he can strain his muscle. The quick change in direction caused by the hooking can strain the muscle, sprain a muscle, or sprain an ankle or hip. Anyway, these quick changes in directions, quick accelerations will usually be the cause of the strains and sprains. As we mentioned, the cause of concussions in hockey can be collisions, and the collisions result in what can be explained by Newton's first and third laws of motion. A body in motion will remain in motion unless acted upon by a force to change the inertia. In every action, there is an equal and opposite reaction. Three of the forces that are applied to a hockey player that can result in a concussion can be applied from another player, the boards, or the ice. A concussion, when a player is moving in one direction and is forced to stop, depending on which direction he's forced to stop, the brain will come forward and collide with the skull, and then in the opposite direction it will be forced back and again possibly collide with the other side of the skull. A high school hockey player collides with another player intentionally or accidentally may experience enough force to cause an abrupt change in motion, which would result in a trauma to the brain. Also, collision with the boards or fall to the ice also change that direction, and they have an equal and opposite force, which may cause trauma to the brain. What happens in a concussion is the brain cells or the brain membranes are damaged, which cause an abnormal movement of calcium, potassium, glutamate, and other substances within and out of the injured cells. Blood supply will be cut off or restricted to the damaged cells by the body systems. And this chemical imbalance and restriction in blood flow results in the brain cells becoming dysfunctional. Symptoms of a concussion: the athlete will be disorientated, may have a blank stare in his or her eyes. There will be difficulty keeping the eyes open. They will have could have slurred and incoherent speech. There would be a delay in responses, and there would be gross coordination. An athlete suspected of a concussion should be assumed to have possibly suffered a cervical spine injury, and until such a time as that possibility of an injury can be excluded, the athlete should be treated as if there was a possible spine injury. What's recommended these days is that a SCAT-3 test be used to assess the athlete's condition. This is the Sports Concussion Assessment Tool. I don't have an example of it here, but it is a survey and observation guide to assess the symptoms of an athlete, his physical, emotional, and cognitive symptoms. If an athlete is suspected of having a concussion, the symptoms and should be reassessed again the following day and possibly even the day after that. The symptoms can change over time. Shoulder injuries. In high school hockey, the mechanism for these injuries is again the same as concussions. It's collisions with other players, with the boards, or with the ice. Shoulder injuries include dislocations, separation, fractures, and strains. A dislocated shoulder is where the humerus is dislocated out of the glenohumeral joint. This happens when the force of the collision overcomes the restraining forces of the joint. The restraining forces of the joint are the rotator cuff muscles, which are the supraspinatus muscle, the subscapularis muscle, the infraspinatus muscle, and the teres minor. Tendons, muscle and their tendons, and the ligaments surrounding the shoulder muscles, shoulder joint. And this includes the labrum. The dislocation can happen in any one of 4 directions out of the joint. However, the most common are posterior-anterior dislocations. Again, as I mentioned, it's when the force of the collision overcomes the static restraints of the joint. Assessment of a dislocation can be done by observing the athlete, the position in which the athlete holds his arm, an abnormal contour of the deltoid. The humeral head will be palpable, and movements of the arm will be limited and painful. Separation occurs at the AC joint, the acromial clavicle joint, where the clavicle bone meets with the scapula. The shoulder separation is again caused by collision and results in a partial or complete tear of the acromioclavicle or the coracoccygeal ligaments. Symptoms will be pain and difficulty in moving the arm. Assessment is accomplished by applying pressure on both sides of the shoulder joint and the AC joint. When pressure is applied, the athlete experiences pain, it's a positive indication that there is a shoulder separation. Fractures. So the clavicle can also be a common injury of a high school hockey player. The clavicle is the bone between the sternum and the acromial process of the scapula. It is also referred to as the collarbone. It's part of the shoulder girdle. The clavicle can be fractured as a result of collision. Fracture can be assessed by observing the shoulder. There will be severe pain in the shoulder, inability to raise the arm, possibly witness a bump above the clavicle. The shoulder will probably be sagging. There would be redness, possibly bruising and swelling and tenderness around the shoulder. Strains and sprains. A muscle strain happens when the muscle is stretched beyond its limit. It is pulled, torn, or ruptured. Again, these injuries usually occur from collisions, falls, loss of balance. They can also be the result of a quick acceleration, a quick stop, a change in direction. Common strains in high school hockey is players' groin, the hamstring, the lower back, the rotator cuff muscles, or the abdominal muscles. There will be a sharp pain the athlete will experience a sharp pain in the muscle that has been strained as soon as the injury occurs. Depending on the severity of the strain, there can be swelling and bruising. The muscle will be sore while resting and will be painful when activated. The affected muscle will be weak. Sprain is the stretching or tearing of a joint ligament. There are 3 grades of sprain. There's grade 1, which is a slight. High school hockey players will most commonly sprain their knee, wrist, and they have a unique sprain that they experience in their ankle. The mechanisms for these type of injuries are collision, direct blows, falls to the ice, falls against the board, planting, and twisting motions. The symptoms will range from mild pain in a grade 1 sprain to severe pain in a grade 3 sprain. Tenderness and swelling as well as bruising will occur and will vary depending on the grade of the sprain. Hockey players experience high ankle syndesmotic sprains. This is the unique one I was explaining. The sprain occurs when the skate becomes trapped in the ice and the foot is turned out, external rotation, and in a dorsiflexion position. The anterior and posterior tibiofibular ligaments, which are distal on the tibia and fibula and extend up the leg as a syndesmotic ligament, will be stretched during or strained, torn when an athlete falls. Hockey players oftentimes will injure their MCL, medial collateral ligament, more so than they will their anterior crucial ligament, ACL. MCL attaches above the joint line of the medial epicondyle of the femur and below the tibia. MCL sprains are a result of abduction and internal rotation. Assessment of a sprain begins with a series of questions. If the athlete wasn't observed, if the injury wasn't observed when it takes place, ask the athlete what position they were in when the injury occurred. Did the knee collapse? Was there any sounds like popping? Can they move their knee? Did it lock after the injury? And then survey the leg to see if the knee, to see if there is swelling and pain. Assessments of sprains. The MCL ligament can be assessed by having the athlete lying in a supine position with the legs straight. The athlete will hold the ankle in one hand and place the other hand on the head of the fibula. The trainer then places inward force, valgus stress on the extended knee, and also at 30 degrees. Laxicity would be an indication of a strained knee. The ankle sprains, the syndesmotic sprain, high ankle sprain, can be assessed by externally rotating or dorsiflexion of the ankle. Pain on the anterior lateral leg would be a positive sign of a sprain. Wrist sprains can be caused by collisions or falls. Symptoms would be restricted motion, pain, swelling. Severe sprains should be referred to a physician for X-ray.